So, good afternoon, all. Today we are having a very good case discussion. Dr. Deepak beautifully named it as a story of a pregnant physician, but very common for the ER physician and for the critical care physician. When you get an obstetric patient to emergency, from the emergency to the ICU, this scenario is basically a 24-year-old, 24 weeks obstetric patient coming to ER with fever and breathlessness. And how do you evaluate, and then how do you manage how the sepsis is different in obstetric patient when compared to non-obstetric patient? So to moderate this session, we have Dr. Deepak. Dr. Deepak has done his critical fellowship after his MD internal medicine, and then now he is the lead consultant cardiac sciences ICU at Apollo Hospital, Hyderabad, and he is executive committee member of ICCM Hyderabad chapter, and he's a very good academician, and he's a national speaker. So Dr. Deepak will be moderating this session, and he will introduce the panelists. Thank you. Over to Dr. Deepak.
Thank you for your kind words, sir. I welcome the other senior esteemed faculty. Rajesh sir, he doesn't require an introduction. Well-known speaker and well-known author and teacher for most of us. Happy to have you, sir. And Dedipya sir is also one of the close mentors and we used to go for his lectures to Chennai. And good to have you, sir. And another interesting panelist is the senior sister, Ms. Vinodini. Thank you, Vinodini sister, for joining us. We'll be interested to hear from you how the nursing aspects of the care of a critically ill pregnant patient. So let us go into the part per se. So this is a story of a pregnant female. The story starts like this. 23-year-old primigravida woman, around 24 weeks of gestation, who presents to the emergency with fever since 2 days and shortness of breath and fatigue since 2 days. Just when you're going through the presentation, just imagine that you're at the ER and see kind of setup for what's going on. This pregnant lady, she doesn't have any history of cough, asthma, chest pain, hypertension, or contact with a known COVID-19 patient. And she was on regular vitamins and iron supplements, not on any chronic medical illnesses or any chronic medication. Regularly goes through a prenatal care in the hospital and routinely gets investigated. So this is the presentation, initial presentation. And when you examine this pregnant lady, she's anxious, febrile, around 100.1 degrees of Fahrenheit, tachycardic. Blood pressure seems to be reasonable. Respiratory rate is around 30 per minute, slightly tachypneic. The saturation is 94% on room air. These are the vital signs. And when you auscultated her, there was bilateral air entry with no added sounds or murmurs. And per abdominal examination, it's corresponding to 24 weeks, the fetus. And fetal heart sounds are 160 per minute. And when she came, the registrar or the junior doctor at the emergency, they have examined this patient and sent her back with a tablet of azithromycin, 500 mg orally every 12th hourly for 3 days. So this is the initial case scenario which you're encountering. So coming to the first question, we have a lady, 24 weeks with respiratory illness, obviously, a bit hypoxic, tachycardic, tachypneic. Rajesh sir, what's your initial impression of this patient and how does your approach differs from a non-pregnant patient? Rajesh sir. If Rajesh sir has some difficulty with the audio video, Dedipya sir, can you take this?
No,
Rajesh sir is there.
Because you see, audio and video get disabled if you get disconnected. So
yes,
somebody
sir.
needs to see that if it is disconnected, to put it on.
Sure,
I was
please.
just waiting for.
Yes. Sir.
Thank you so much. So, this is a lady, 24 weeks of pregnancy, presenting with a fever and shortness of breath. In the current scenario, if it was yesterday, I would think COVID as my first diagnosis, because you see, when there is some epidemic or pandemic going on, you should think that as a first possibility, because otherwise, any lady who has having these symptoms, you should think, because there is a fever, so I would think infection as a first possibility. And infection could be viral. It could be of course, one is a COVID infection or any other virus. Then these ladies are very prone to get urinary tract infection, aspiration pneumonia because of the gastroesophageal reflux, or even a community-acquired pneumonia. If there is a history of vaginal discharge, you should ask, then probably chorioamnitis. So these are the common infections, and then any tropical fever, because we are still staying in a tropics. So of course, the malaria, dengue, all these should come into your mind when you are seeing such a patient. But if you see the breathlessness, if it was an acute breathlessness, and the other thing which you should never forget with a fever of 100 is a possibility of DVT or pulmonary embolism, because this can occur any time of the pregnancy. It's a procoagulant state, 5, 8, 9, 10 factors are increased. The protein S is decreased, and because of the estrogens, and the ladies do not move much, many of them. So you must think of pulmonary embolism. But usually this would be, DVT is more common than the pulmonary embolism. It will be more of an acute process. Fever, you could get 100 fever with a DVT. But I would think first possibility as infection, as I said, viral in the current scenario. And in that order, I would like to rule out them by taking further history and the examination of the patient.
Thank you, sir. As you rightly said, I think both the septic process and non-septic conditions, both of them have to be evaluated methodically. Does this patient being a pregnant patient, does your approach changes, sir, when you compare with the non-pregnant lady?
See, as far as, you only thing is, rest of the tests are going to be same. But if any radiology is required, there I may choose for a non-radiological as far as possible. But if it's essential, unless, any of these chest diagram or even CT angio if required, they do not have that much of an impact as it is thought of if it is very essential. But then you should go for the non-radiological investigations. So in addition to the usual investigation, like we get the bleeding, the counts, the KFT, LFT, blood cultures, ABG, they should always be sent in such a patient, because shortness of breath is there. And as you said, patient was sent home. And shortness of breath, I'll be a little reluctant to send a patient home because the shortness of breath was there. So I will do since I do not know whether it is sepsis or not, because I have not got the organ dysfunction by getting the test. So I will get all the tests, blood, and maybe if there is any respiratory symptoms, I would put an abdominal shield and probably take a chest X-ray after I have ruled out that there is nothing else. If I do a urine and I find full of pus cells, probably that would be the reason. So if I do not find any reason and there is a symptom, the respiratory symptom, I would put an abdominal sheet and even do a chest X-ray. Although you can do an ultrasound, but in a patient who doesn't have a symptom or nothing on examination, you may get something, you may not get something.
Thank you, sir. Any comments from the other panelists?
Yeah, Dr. Chawla sir covered almost all the aspects. And we must remember that we are dealing with two lives, mother and the fetus. And as Chawla sir said, like initial what investigations and how to take care of the mother when you are sending the patient for any investigation like CT. And one more thing is the type of antibiotic, what antibiotic you have to select. That you have to see carefully. You have to select an antibiotic which doesn't have any teratogenic effect. So the drugs play a very important role, what type of drugs we need to select. Otherwise, I think Chawla sir covered all the aspects.
Right, sir. So there is a special set of people and both the lives are at stake. So we need to have a specialized approach, protocolized approach. And coming to the second question, what are the physiological changes that occur in pregnancy and how does they impact the patient with critical illness, especially in pregnancy? Subba sir.
Thank you, Dr. Deepak, for taking us through the case. And I think the Chawla sir also covered some physiological changes which happen during pregnancy, We'll go by system wise. He already displayed the slide. If you look at the cardiovascular changes, so there is already decreased arterial pressures, increased heart rate. So there is increased risk of hypoperfusion in sepsis. So abnormal baseline may mask some signs of sepsis. So if you look at genitourinary changes, there is increased vaginal pH, and then this will predispose for the chorioamnitis, and decreased esophageal tone, as Chawla sir said, again, delayed gastric emptying may cause aspiration pneumonitis, and then they increase the risk of then the increased aspiration risk with airway interventions. We like intubation, whatever we do, there's a risk of aspiration that we have to keep in mind. And there is increased production of factors 7, 8, 9, 10, 12, and 1 Willebrand factor. All these things can lead to there is a pregnancy is a procoagulant state, and then we must take care of anticoagulation during admission. And then they are prone to develop DIC very early in sepsis, and because of the increased plasma volume and without proportional increase in the red cell mass and hemoglobin, can lead to physiological anemia and decreased O2 supply to the tissues. And the most important aspect is now we are discussing about fever with breathlessness. We must remember the respiratory changes happen during pregnancy. The respiratory changes are increased tidal volume. We know the minute ventilation increases, but not the respiratory rate. The tidal volume and the minute ventilation increases, and respiratory rate is not changed. So decreased residual volume due to elevated diaphragm. So these people, they will have less PaCO2. So they will have like a respiratory alkalosis and decreased oxygenation with a faster rate of desaturation. They're prone for desaturation very early. So when you are intubating, we have to be very, very careful, and we should not allow desaturation. And again, Dr. Chawla said urinary tract infections are common in pregnancy. That is because of urethral dilatation and increased vesico-ureteric reflex. So this increases the risk of pyelonephritis. So anything you want to add?
Yes. Before I finally conclude this point, any comment from the other panelists, Vidya sir and Vinodini sister? So you need to unmute, sir. Dedipya sir.
I think he's elaborately covered most of the physiological changes. Obviously, just adding on, there are changes in the cardiovascular system as well, where there is a physiological anemia of pregnancy because of hemodilution. The cardiac output increases in the second and the third trimester. So we need to really keep that on the back of our mind as well. And because of a physiological vasodilatory state, you do have a decrease in the arterial pressure. So systolic blood pressure by itself comes to a lower level in pregnancy than in the non-pregnant state. And as you can also understand, because of the increased plasma flow and the increased GFR, the creatinine also comes down. So physiologically, if you look at it, a creatinine of 0.7 or 1 is normal in the non-pregnant state. But if you have a creatinine of 1, that's not normal in the pregnant state. In fact, a creatinine of 1 or 1.2 in the pregnancy indicates that this particular patient does have mild renal impairment. In fact, 1.5 creatinine is moderate renal failure in pregnancy. So these are the other changes that I would probably want to add to what is said.
Right, sir. Right. Thank you. So the summary of this point would be it's a complex physiology where both the second two circulations are there and both are interlinked, and almost every system in the body undergoes a lot of changes, and there's a distributive component as well, and it impacts in a lot of ways the management, as it was rightly told by all the panelists. The lung changes, the respiratory capacity. So even though the respiratory rate remains unchanged, the tachypnea, first sign of underlying pathology is a tachypnea in a pregnant patient. So we need to keep a watch on that. And usual normal PaCO2 is on a lesser side, where it is around 27 to 34 millimeters of mercury, as opposite to the normal adult patient who is non-pregnant, which is around 40. So if you see even a normal PaCO2 around in the 40s, that means that there's some amount of pathology, there's an amount of respiratory acidosis, and you need to go and evaluate the causes for it. And PaO2 usually will be in the range of 9 90 to 110, and you need to keep a target above, at least above 75, so that the fetus doesn't have an hypoxia. And coming back to our patient, this patient, as it was told, and in fact, all of us were really uncomfortable in the first scenario, where why the registrar has sent her back, especially when the patient was saturating around 94 on the room air. So coming to this patient again returned back to the emergency with worsening of shortness of breath. And this time on examination, her temperature has increased. It is around 101 degrees Fahrenheit. She is more tachycardic, around 125 per minute. Even her blood pressure started dropping. It is around 88 by over 54. And she is more hypoxic than the previous setting, where it is 89 SpO2 on 8 liters. She's tachypneic. And this time on auscultation, there were fine crepitations on both sides in the basal areas. On per abdomen, the gestation is more or less the same, and there's no abdominal pain, and there's a decreased urine output as well, the clinicians has observed. And now the clinician has started an IV antibiotic, started thinking there was a sepsis, and cultures were sent. So this is the development of the previous case scenario. So Dedipya sir, what are your differential diagnosis in this patient? This patient has initially presented, somehow she got missed and sent back her home, and again this patient presented with a progression of the scenario. What is your take on this?
Okay, I think this question was already answered in great detail by Dr. Rajesh Chawla in the beginning, but yet I'll take this. So I see that you've asked me to differentiate whether it is sepsis or non-septic. Well, it's going to be a very difficult decision to make. What we used before was use the SIRS criteria. So if you look at the SIRS criteria that we using before, initially the temperature was elevated, the pulse rate was 120, and the respiratory rate was 30, which means even at the initial admission to the ER, the patient did have the fulfillment of the SIRS criteria, 3/4. Well, for us to call sepsis, in addition to SIRS, you need to have an infection. Of course, since we now don't use SIRS criteria, I'll not dwell on it. Let's look at the QSOFA criteria. The normal QSOFA criteria in the non-pregnant state is to look at the altered mental status, which is not present in this particular patient. She was conscious, giving the history. Respiratory rate more than 22, and systolic blood pressure less than 100. But this is for the non-pregnant state. But in pregnancy, there's been some modification. They've increased the respiratory rate to 25, and they want the systolic blood pressure to be less than 90, because we say that there is a physiological drop in the blood pressure in pregnant state. So if you look at this, she doesn't meet the QSOFA criteria in the ER. Her second visit to the ER now, she meets the QSOFA criteria. So anybody who meets the QSOFA criteria, we are very much bothered that they may have sepsis. So we have to think in terms of whether they are sepsis. This is an idiot's guide to run in the emergency. But having said that she was tachypneic, she probably needed an extended ER observation, if not an admission, at least an extended ER observation rather than an outpatient discharge. I think considering all of it, considering that the patient has got a QSOFA positivity with 2 criteria in terms of respiratory rate and in terms of our systolic blood pressure 88, which is less than 90, which is the modified QSOFA in obstetrics, I think this patient is likely to be septic and we need to investigate. And I understand that blood cultures and respiratory cultures, maybe the respiratory viral panel COVID tests were all done. I'm not sure whether she has urinary tract infection, because we don't usually treat asymptomatic bacteria in pregnancy. She's an alert person. She's not complained of any urinary symptoms, and therefore we probably sent a urine routine. I'm not sure in the absence of symptoms whether she would we need to consider that as a possible source. Now, could it be non-septic? Yes, it could be non-septic. It could be referable to the cardiac or the respiratory symptom, or correlate on both. In terms of the respiratory system, I think acute pulmonary embolism is a possibility in this particular patient, given that she's especially in the second semester, beyond 20 weeks, you always expect hypercoagulable state, especially APLA can all happen after 20 weeks. So that's where she is. well, can she have aspiration? Yes, she could, but she's a conscious patient who's not given us any history of aspiration. So probably I'll keep that in the back of my mind and rule it out. Can she have acute exacerbation of asthma, which can present? Yes, possibly, but you've said clearly that she has only fine creps and there's no wheeze at all. And it's not like a silent chest. So you're hearing something, but it's not wheeze. So maybe that it is not. So I think if you're talking about the respiratory system, acute pulmonary embolism is a possibility. And talking about the cardiac system, well, whether she's got a peripartum cardiomyopathy is something that you'll keep in mind, but usually that happens 1 month prior to delivery to 5 months later, is it not? So she's well away from it, so it's not peripartum cardiomyopathy. Is she had any lesion that was probably not picked up in her pre-pregnant state? Maybe a small ASD that only comes to light. Maybe she had pulmonary artery hypertension, primary pulmonary hypertension, which is just picked up because of the hyperdynamic circulation of pregnancy, or she had a mild valvular lesion, mostly stenotic lesions, which gets picked up by pregnancy. So she would need echocardiographic evaluation as well. So I think that would be my differential. If you're asking whether it's sepsis or non-sepsis, I would say that because the Q SOFA is positive, I will think in terms of sepsis, and sepsis is something that we don't want to miss early on, because if you miss it and not treat it, you could have bad outcomes, especially since she's now becoming hypotensive. So that's something. Of course, there are a variety of non-septic conditions. Top of my list would be acute pulmonary embolism and maybe stenotic lesions or a primary pulmonary hypertension of cardiac origin that we need to keep in the back of our mind. Thank you.
Perfect, sir. Thank you for summarizing the proper differential diagnosis of this sick patient. I think it benefited the other audience as well. So coming to the next question, this is a patient who is having multi-organ involvement, multi-organ dysfunction, whereas she is in septic shock, she has a hypoxia, worsening urine output, and seems to be pretty sick. And along with it, she has a fetus as well. Ms. Vinodini, what are the practical difficulties you face in nursing management, especially in a critically ill pregnant patient? How does it differ from the routine patients, non-pregnant patients?
Thank you, sir. So regarding this patient, so what are the basic difficulties usually, because we are going to handle two lives, both the mother and the fetus. So first of all, we have to counsel the patient, sir. If the patient is like conscious, already it was not conscious, she is conscious only. We have usually pregnancy is a stressful period for us, right? So we have to mentally prepare her that we have to counsel the patient as well as the family members. So if the patient is like critically ill, the normal nursing management will be like, what the difficulties we face is the patient may be dehydrated. So we have to make sure that the hydration is fulfilled, and the complete history collection should be made by the complete history collection should be done, and we could rule out what would be the cause for the sepsis. So we have to do all the septic parameters, which and whatever necessary for the patient, and we have to triage the patient as soon as possible to stabilize the patient. So to involve all the concerned departments to evaluate and diagnose early and treat both mother and fetus. So the major difficulties we face, like we mostly worried for the fetal heart rate only, sir. Immediately, if the patient is like anxious and uncooperative, means first we'll check the basal fetal heart rate. If it is like 110 to 160 means, so we will be reassuring that the fetus activity is present. So if once the patient is stabilized, we can go for the baseline cancer. So major difficulty we face to stabilize the patient and to look after the basal fetal heart rate. So how the routine ER nurses will handle the sick pregnant means, so most of the patients, most of the nurses who practiced in ER, they'll be attending both ALS, BLS as well. So there should be a specialized trained nurse to handle maternal obstetrics also. So we can go them. The routine preparedness of the ER nurses should be, first we have to triage the patient according to the patient's condition and the history. So we can just explain and counsel the patient's family members that she's going to be critically ill, and we are going to move to a particular dependent area for the further management. If she is dehydrated, we have to stabilize the patient with adequate IV fluids. If we are suspecting that it's a sepsis patient, we have to do adequate septic parameters. So what preference, we don't know what infection this patient is brought about. We can think of COVID also. So the proper donning and doping and universal precautions for the safety of the patient as well as the nurses who handling them should be like monitored, sir. So once all this done, so in spite of tender loving care, we must be do a care which should be very fast, and we have to act smart and fast, sir. So these are the routine will be handling with the sick pregnant mothers.
Thank you, sister. Subha sir, about the definitions of sepsis in obstetric patients, does it differ from the non-pregnant patients? Like we routinely use our surveying sepsis guidelines, all those guidelines. Do we have to have a different approach and different definitions?
Yes. And before that question, I would like to congratulate Dr. Ravi Mahajan. Initially, I forgot Dr. Ravi Mahajan and you, Dr. Deepak, for involving a critical care nurse in the panel, so that you will give a proper comprehensive critical care approach to a patient. So what are the nursing aspects? Generally, this is missed in all the panel discussion. And thank you so much, Ms. Vinodini, for answering the nursing aspects, and it is really good. And so coming back to my question, the definition of sepsis, is it different from the regular non-obstetric sepsis? So the World Health Organization defines maternal sepsis as the organ dysfunction resulting from infection, abortion, or postpartum. So if you look at the common sources of infection, as Dr. Chawla mentioned before, so you divide into antepartum and postpartum in obstetric causes and non-obstetric causes. If you look at the obstetric causes during antepartum period, septic abortion can cause sepsis, chorioamnionitis, and then the non-obstetric causes like urinary tract infection, pneumonia, and appendicitis. And if you look at sepsis in postpartum ladies, and then it is maybe because of endometriosis, wound infections, surgical site infections, and urinary tract infection, pneumonia, and gastrointestinal causes are very common. And again, if you look at the scoring systems, we have, as Dr. Diripia said, we have a modified Q-SOFA, like that we have a SOFA scoring, specially modified in obstetric patients. And then we have sepsis in obstetric score, SOS. And this is validated and then it is published in Obstetric Medicine Journal in 2019. And then in this tool, we have temperature, we have systolic blood pressure, we have heart rate, respiratory rate, saturation, WBC count, and then the percentage of immature neutrophils, and then lactate. Dr. Deepak already displayed this slide, the sepsis in obstetric score. And we know as a physiological change, the WBC count is always is elevated up to 16,000 is normal in a pregnant lady. So that's why we need to modify the sepsis scores in the obstetric patients. And this SOS score, SOS more than 6, and it has a sensitivity of around 88% and specificity of around 99%. And then it has got a huge positive predictive value. And then when how to identify sepsis in an obstetric patient is a real challenge. When you have a patient in the ward, or when you get a patient to the ER, and then you have to follow some scoring to identify sepsis in obstetric patient. If you look at this early warning, modified early warning score, the regular early warning score may not be applicable for an obstetric patient, and then we have a modified early warning score in obstetric patient. But still, when you if you validate these scores, this sepsis score in obstetric score, that is more than 6, is better in identifying septic patients, better than positive predictive value is more when compared to modified early warnings score. And then when the score is more than 6, so it is associated with positive blood cultures and fetal tachycardia. So this is how we differentiate. Already, I don't want to talk about SOFA. There's a modified, obstetrically modified sequential organ failure assessment score. And Q-SOFA already Dr. Diripia explained in his talk. So this is how the scoring systems and sepsis and causes of sepsis differ in obstetric patient when compared to the non-obstetric patient. Thank you, Deepak.
Thank you, sir. So to summarize what the panelist was saying, so you have a specific score, sepsis in obstetric score, and you need to use a specific definitions. Maybe need to have a setting in your mind, whether it's a postpartum or peripartum state, and ultimately it is well validated and it has a good predictive values as well. And SOFA score, when you're using a QOQ SOFA, I think you need to have a obstetrically modified score. So coming back to the panelists, just so Rajesh sir, coming question for you. This patient we have seen in the initial presentation and second present, there was a bit of difficulty with the triaging of the patient. In fact, how do we actually triage a patient with respiratory tract infection in emergency, sir? Especially in a pregnant lady who are very vulnerable. How do you like where to admit them?
You see, now there is no doubt that this patient requires admission to the ICU, and it should be an isolation because, as you also said, they are prone to infections. So a patient who's got a septic shock or requires respiratory support, there is no doubt that the person should be in the ICU. So this person should be admitted in the ICU in an isolation room. That's what I think.
Yes, sir. About the severity scores, I think it was like extensively covered by Subha sir. And Dedipya sir, why do you think the routine scores like PSI, Apache scores are not accurate in pregnancy, and why do you need to have a more different approach in this one?
Yeah, see, clearly when you look at the PSI or pneumonia severity index or the POTS score or the Apache score, of course they look at a lot of other parameters like age, gender, and CNS involvement, etc. But they also use a variety of organ specific scores. They look at the blood pressure, they look at the respiratory. For example, Apache score looks at the blood urea nitrogen, creatinine, etc. So since we've already said that in the pregnant state there is an alteration of these organ failure scores, therefore you need a modification, and this modification has to be validated. It has not been validated in the non-pregnant state, and therefore you cannot use the pneumonia severity index that has been validated for adults including non-pregnant females, or the Apache score which has been validated cannot be used because it's not validated in the pregnancy. So that is basically why we cannot use it, because these PSI and the Apache, by using them, we use them to portend high mortality or morbidity if the score is worse. So since in pregnancy this has not been validated, you cannot say this to give an information that is not justifiable. That's exactly why we don't want to do it. And as you've put in rightly, for example, we've already talked about the creatinine, so I'm not going to go to it again. Let's look at the example of a WBC count, as very well put out on the slide. The WBC count female is said to be abnormal, but in pregnancy you will have a physiological elevation of a WBC count. So it is okay to have a count of 14,000 to 15,000, which if you're going to take it in the scores, it will be calculated as abnormal, and a falsely high morbidity or mortality will be predicted for this particular patient, which is not what we should be doing.
Thank you, sir. So again, coming back to I think before we take this question, I think one small bit of information need from Mrs. Vinodini. How do we actually monitor the fetal status when the patient is pretty sick and admitted in the ICU? How the nurses monitor the fetal status? Can you please tell us? Sister Vinodini?
Yes, sir, I'm here. So since the mother is actually 24 weeks of gestational age, so baby mother is in the viable, the fetus is in the viable period. So monitoring of fetus, like immediately if the patient comes to ER, we can just check the fetal heart rate. If the baseline is like touching 110 to 160 beats per minute, so it is reassuring. So we can do all the parameters, what all the things to be done or the investigations to be done to stabilize the patient, we can do. Since the continuity of the fetal monitoring is not actually necessary, like usually we'll monitor the fetus every fetal heart rate, usually every 4th hourly. About 28 weeks, which is a mandatory one, to be monitored every 4th hour. Since the fetus is in a viable period, we can check the reassuring heart rate. So we can stabilize the patient and we can go for the baseline scans for fluids, for any bleeding or any uterine abnormalities like the flow, diastolic flow and all. Once the patient can be stabilized, and we can go for the basic scans. So frequently monitoring of fetal heart rate is not mandatory. We can reassure that the heart rate is like in the viable period.
Thank you, sister. As it was rightly summarized by the panel, all the panelists, I think till now the summary has been you need to have a specialized approach for the pregnant ladies, especially in this patient seems to have a severe pneumonia as well with shock and multi-organ involvement, aka hypoxia as well. So just to put a point, you have a major criteria and minor criteria. Any patient who needs a mechanical ventilation or has a hemodynamic compromise, they classify into a severe pneumonia. And the minor criteria involves the other parameters as shown in the slide. And IDICA guidelines, again, that says the more or less the same thing. One or two things we need to take in account is the thrombocytopenia. What is the baseline thrombocytopenia? Even the hypothermia is as important as the hyperthermia as well. So try to identify the severity of the pneumonia as early as possible so that we can better manage the patient. Coming back to the panelists, Subha sir, how do you investigate this patient? And the specific question, once we know the baseline investigation, what is the, I think Rajesh has put a word in the initial part, but we'd like to know about you. Most of the people are scared about getting an X-ray or CT in the pregnant ladies. Do you agree with it? And what's the take on it?
Yeah. See, this patient definitely will do the regular investigations like complete blood picture. We do the renal function tests. We do the blood gas analysis. We do chest X-ray, and chest X-ray, doing chest X-ray, how safe it is, will come to that. And then we can do the blood workup, the CRP, D-dimer, procalcitonin, and ultrasound chest. We know we use lung ultrasound very frequently, and it is very safe. And now the fetal scans, now the fetal X-rays are totally replaced because of the ultrasound. And then we have a ventilation perfusion scan, which can be done when, like, if you are suspecting, as Dr. Chawla said, if you are suspecting DVT or PE is a non-infectious cause of fever with breathlessness, then we can safely do ventilation perfusion scan. And when you are not getting answer with all these things, and mini ball is one answer, and then we can do this PCR testing. We can depend on these because most of the time when I get a fever, pregnant lady, 24-week gestation with breathlessness, we have to rule out like COVID-19, even though there's no close contact. You said in your history, she was going frequent antenatal checkups. So COVID-19 and then H1N1, we can do multiplex PCR upper respiratory panel. And then how safe is your chest X-ray in 24 weeks gestation? See, generally more than 24 during 24 weeks of gestation, by the time they know like they're pregnant, they're going for frequent antenatal checkups and all. But many people before coming, before knowing that they're pregnant, they go for these health checks. So we know the fetuses are highly sensitive to radiation. And then the incidence of these effects has a time specificity. So when they know, before they know that they're pregnant, when they go for these X-rays, when they go for health checks, and then they do these imaging, so that radiation exposure we need to avoid. So the radiation exposure exceeding 0.1 gyri at an early pregnancy, that is pre-implantation period, may lead to miscarriages. And we are now talking about 24-week gestation. Here, all these radiation effects are very prominent when it is more than 5 rads or more than 10 rads. But your X-ray is very safe. And then if you are doing more than 100 X-rays, that may be causing problem for the fetus. Otherwise, during organogenesis period, as I told, we should not exceed 0.1 gyri. So if we exceed 0.3 gyri, and then it can affect the cerebrum, and then it can cause mental retardation in pre-implantation stage. But no single diagnostic procedure results in radiation that threatens the well-being of developing fetus. The fetal risk is considered negligible at 5 rads, as I told, and exposure less than 5 rads has not been associated with any increase in fetal anomalies or pregnancy loss. So ultrasound there's no contraindication for ultrasound, and ultrasound is very safe. And all of us are experts in lung ultrasound. We can rule out many causes. We can rule out pleural effusions. We can rule out. We can see whether consolidation are there or not, or we can see whether B lines are there. Tocolytic induced pulmonary edema. All these things we can diagnose by looking. With the ultrasound. And so, as I told, the pre-implantation period. Sorry, it was disconnected. Sorry, now I think it's connected. Pre-implantation period, we have to be very careful during organogenesis, and during pregnancy. If it is more than 10 rats, then only it causes growth retardation, mental impairment, and all. And I think Dr. Deepak showed in the slide. So this is the risk and threshold doses of the main effect of prenatal irradiation. And next slide, you can show this how much a skull X-ray gives how much radiation. A skull X-ray gives 0.004 radiation. The rats. I told if it is more than 5 rats, then it can cause problems with the fetus. Otherwise, we have to be careful with abdominal CT scans. We have to be very, very careful CT scans. And then if you're doing a lumbar CT, then we have to be very, very careful. Otherwise, the chest CT we can do with the shield. We can cover the abdomen with a shield, and then we can do CT chest if it is required. As far as possible, avoid it. But if it is mandatory, we can do a VQ scan if you want to rule out PE, and we can do CTPA also with proper precautions if you have to do if it is mandatory.
Thank you, sir.
Thank you.
So Rajesh sir, I think we all agree with Subha sir in the way if it's really necessary, I think we'll always go for an imaging. Just a confirmation from you, I think most of us, ultrasound has replaced the routine imaging techniques. And how do you actually use the point of care ultrasound in your ICU, sir, especially when you have a pregnant lady in this setting?
Point of care ultrasound is used, of course, in a pregnant lady by all the obstetricians very commonly to know the age of the pregnancy, whether it is ectopic or extra ectopic or a normal pregnancy, gestational age. For any problem in the abdomen, it is used very commonly, point of care ultrasound by the obstetrician. And for any problem, if you use a point of care ultrasound, even for the chest, we've been using, if person has a problem, if you use that, you can really in no time you can find out what is the reason for the breathlessness. Like if pulmonary embolism, it takes 10 minutes if you use the ultrasound, and you can really find out. Of course, it is a problematic doing ultrasound in a pregnant lady, but I think it is a very useful modality. If you are little trained, you can really find out what is the etiology of breathlessness. Like if you find a B line or there is absence of B lines for differentiating pneumothorax, pulmonary edema, in the consolidation, all these lesions can be easily found out by point of care ultrasound in these individuals, and you can avoid radiological investigations.
Thank you, sir. So it's imperative on most of the students and both the consultants as well to train themselves regularly in point of care ultrasound. Nothing replaces that. So coming to Dedipya sir, sir, what is the role of biomarkers in this setting? And we know there are a lot of biomarkers, CRP, ProCal have been trained. What's your take on the utility and pros and cons of the biomarkers?
Okay, I'll answer this. But before that, I just thought I'll just add, I think we just missed out on tocolytic induced pulmonary edema, which is also possible in this particular patient. I was just thinking because she's 24 weeks and it is possible that she had some premature labor and it was given. So that's something that we need to keep on the back of the mind. And talking about the severity scores, you did talk about the SOS score, sepsis and obstetrics care. I just want to highlight one point of importance here. Especially this is a tool that has come from low income countries, especially in the ED, where if it was used, it had a negative predictive value of approximately 100%, 99.9% to rule out critical care admissions. So if your SOS score is not more than 6, then we definitely know by nearly 100% certainty that this particular patient is unlikely to need a critical care admission or have positive blood culture. So I think among the scores that are available, this is the most validated score, and therefore we should use them, and especially that helps make a decision. And coming back to this question about which biomarkers, well, I think we use a lot of CRP, especially after COVID. But having said that, there is nothing to say that rising CRP or a trending CRP is helpful to make a decision of a patient. It sometimes, if you have a downtrending CRP, it reassures ourselves, but there's no evidence in literature that it is actually telling us that the patient is improving. Likewise, procalcitonin, I think there is most of us who use procalcitonin, there are many settings in which we use procalcitonin. Some of us use procalcitonin for diagnosis sepsis. Some of them use it for seeing whether they are improving, and some of them use it for stopping or de-escalation of antibiotics. It's very, very clear that in non-pregnant state also, procalcitonin can be used only for stoppage or de-escalation of antibiotics, not for diagnosing or initiation or modification, only for de-escalation. That being the case, that should where it should stay even in the pregnant female. But having said that, during pregnancy, there are when you talk about procalcitonin, we need to understand that it comes from a big molecule, and that has to be broken down to give rise to the procalcitonin. There in pregnancy, you do find that there are a lot of changes or immunomodulation that happens, and therefore we are not even sure whether it could be used for that indicated purpose that we use it in the non-pregnant state, that is for stoppage or de-escalation. We do not have it because we do not know what is the normal value of procalcitonin in the non-pregnant state. Maybe in future, if someone looks at it and tells us what it is and gives us a reference range, maybe we could look at it. For at this point of time, we do not have anything to say that procalcitonin should be used or is useful in pregnancy, and therefore, in my view, I would not use this to prognosticate my patients.
Thank you, sir. So our patient, like after that, till now the course, we've been seeing how she's progressing. So there was a pink puffy sputum which was observed after 3 days of admission, and which led to the suspicion of advanced infection with pulmonary edema. I believe she was already in ICU, and she was on high flow nasal prongs, a nasal cannula, and despite that, she continues to have shortness of breath, and her oxygen level started dropping. So she was tried on NIV. The ABG after 1 hour was shown in the slide. The pH of 7.38, carbon dioxide of 44, PaO2 was around 88, bicarbonate was 24, lactate was 1.2. She continues to be pretty uncomfortable on the NIV, and she has to be intubated and kept on an assist control mode of ventilation. So again, coming back to Dedipya sir, I will just go through the loop here. How does the interpretation of ABG differ in pregnant and non-pregnant? We have seen that initially their carbon dioxide levels will be on a kind of lower side, 27 to 34. Can you please elaborate on that?
Yeah, I think it's already been told in the when we reviewed the physiological changes, and you put it in your slide as well. Very well done. So clearly, because the tidal volume increases and the mid ventilation increases, you do have a compensated respiratory alkalosis in this particular patients, where the pH is slightly on the alkalotic side, but very compensated, and the PCO2 is 27 to 34. Therefore, in any patient, if I see a normal PCO2 of say 40, which is normal in the non-pregnant state, in this particular patient, I would say that this particular patient is getting exhausted. Example, if a patient with asthma comes and I do an initial ABG and I find that the PCO2 is 38, to me, it shows that this particular patient is exhausted. Take any other instance, a patient has got acute pulmonary edema from an LVF, and I find that the PCO2 is 40. There again, it tells me that the patient is exhausted, and this particular patient would need more assistance, maybe in the form of NIV, maybe in the form of intubation, whatever it is. This particular patient needs to be closely followed up. So if you see a PCO2 in the normal range, it is an alert for you to realize that this particular patient is tiring out and is likely to decompensate in the next half an hour or 1 hour, and therefore we need to do appropriate methods, whatever be it, whether it's NIV, whether it's diuretic, or whether it is intubation, whatever it has to be kept in the part of mind. And likewise, when you look at the pH, as I said, you would have a respiratory alkalosis, usually compensated, sometimes slightly not compensated. So it can go up to 7.45. But if you're going to see a pH of more than 7.48, it foretells a very, very bad prognosis. So these are things that I would actually look forward. Most importantly, I would look for a PCO2. That is very, very important. And clearly, when you look at the PO2s, as you can see, the PO2s are slightly higher in the non-pregnant state. And that is why whenever we use a SPO2 cutoff of 92 in the non-pregnant state, we always say, in most recommendations, they would always say keep an SPO2 cutoff of 95 in the pregnant state. So I think these are things that I would keep in mind when I'm interpreting the ABG or the pulse oximeter.
Thank you, sir. Rajesh, sir, I think that was a continuation of the last question. Same thing, oxygenation targets, I think Vidya sir has briefly touched.
Sorry, I didn't mean
to. Fair enough, sir. Briefly touched. Anyway, the point was, do you agree with the same approach? Or
yeah, of course. You know, when you are oxygenating a pregnant lady, you know, your responsibility is not only to bother about the lady, but you have to bother about the fetus. So it is said that at least 95%, as he said, you should have the oxygen target, and PO2 of 75, as you can see on this slide. And, you know, this is one condition where you should not maintain permissible hypercarbia. You know, of course, it increases the intracranial pressure, and it is also associated with a detrimental effect on the fetus. So even the growth retardation. And, you know, if this patient is on a ventilator, it's very difficult. You know, on one side, you have to avoid hypercapnia, and you can't overventilate that the pH goes beyond 7.48, because if it goes beyond 7.48, it will cause uterine artery vasoconstriction, like the cerebral vasoconstriction. There also, this causes the uterine artery vasoconstriction and decreases the fetal perfusion. So you have to be very, very careful, particularly if these patients are on a ventilator. But if it's just on oxygen, I think you aim for above 95, and that is one. And if patient is on a ventilator or an IV, you should avoid the PaCO2 beyond 65, and pH should be below 7.48.
Thank you, sir. Sister Vinodini, we have seen in this patient that the patient was not tolerating an NIV. And can you please elaborate what are the approaches, especially are you comfortable in trying the NIV in this setting, pregnant lady, chances of aspiration, the sphincter will be free, and there's a baby as well. So are you comfortable, and what do you want, like what are your nursing approaches when trying to improve the compliance on the NIV? And I think Subha sir, if available, once you finish, he can contribute 1 or 2 points.
Sure.
Sir, actually speaking, trying NAV for the pregnant mothers with 24 weeks is not acceptable, I think. So it is better to avoid NAV, because so already the NAV means there is a risk of aspiration. Since the pregnant mother, already the gastric emptying will be delayed, because the stomach capacity will be turning low, and the low esophageal tone also will be like in the lower side. So gastric emptying will be delayed. So in order to prevent aspiration, NAV is not advisable. So the pros of using NAV means, in order to prevent intubation, to treat hypoxia, we can go for NAV, sir.
Yes, I completely agree with Sister Vinodini. So we should not try NIV in a pregnant lady, 24-week gestation. We have to be very, very careful. As she said, the risk of aspiration is very high. You try NIV, and then there is a lot of gastric emptying when you're ventilating these patients, when you're giving positive pressure ventilation through a face mask, and then when you're trying to intubate, when the NIV fails, that time the risk of aspiration is very, very high. And then if they develop aspiration pneumonitis on top of pneumonia, again, there's underlying pneumonia. So it is very difficult to save. And NIV had to be very, very careful. We should not use NIV in a pregnant lady, definitely in ARDS, whether it is H1N1 or COVID-19 ARDS. Essentially, there are few papers too, they were using HFNC but NIV is very, very risky. Thank you, doctor.
Thank you. So, Rajesh sir, we already seen this patient was in a condition of septic shock. About the aspect of resuscitation of this patient with fluids, I'm like, does the approach will be same as the non-pregnant lady? And how do you actually resuscitate the fluid, the amount, how much ml, what fluid? Can you please?
You know, in a septic shock, it's not going to be much different like non-pregnant patients. About 30 ml per kg, about 1 liter of fluid can easily be given to these. And, you know, as you can see on the slide, the dynamic variable like the stroke volume variation or the pulse pressure variation, these are more useful to monitor the preload in these patients and give fluid accordingly. And of course, passive leg elevation could be used. The ultrasound to see the IVC may not be that much useful, but point of care ultrasound can help in these patients to know that to avoid the overloading, and you can keep on seeing the chest. If you see that the B lines are appearing, then probably, or you can see the cardiac ultrasound and see that whether patient really needs fluid. So all these things together, they can really help you to resuscitate these patients appropriately, not overloading them, at the same time giving them optimum fluid. So I think if patient is in the ICU, dynamic variables would be the way to go in these patients to give fluids.
Thank you, sir. Dedipya sir, another important aspect is the airway management of these sick patients, pregnant sick patients. We all know it's a very difficult aspect, especially when there's a crashing pregnant lady. It's a panicky situation. Can you please let us know, like, how does it differ from non-pregnant, and what are the measures we need to take so that it would be a safe procedure?
Okay. Well, just talking specifically of the airway and possibly about how we are going to intubate and all of it. So clearly you understand that pregnancy is a state where there is hyperemia, a lot of edema. So when you open the mouth, there would be a swelling of the tongue, there would be hyperemia. So you need to be very, very gentle. So otherwise you will cause a lot of airway injury. Usually most of us bag mask our patient, pre-oxygenate our patient, and then get it to 100% for about 2 minutes at least before we attempt an intubation. We've already mentioned how the residual volume is much less in pregnancy, and therefore, and rather the functional residual capacity is also does affect it. And really bag masking is also a challenge in this particular patient, because if you're going to bag mask ventilate these patients, you are increasing the chance of aspiration, kind of given that the gastroesophageal sphincter tone is much lesser, and therefore the reflex is much possible. So therefore we could give them 100% oxygen. Either don't use the ambu bag much, or if you're using it, be very, very gentle to do it. So that's something that you need to keep in the back of your mind. And remember that it would be slightly difficult airway compared to the non-pregnant state because of the distortion of the anatomy, as we have said. And moreover, you find that the distance from the 332 rule will all be altered in it. So it's going to be very, very difficult in pregnancy, especially because the diaphragm pushes the chest up. So that's also going to be very difficult in intubating these patients. So these things that we need to keep in our mind. Of course, this is a challenge, but I think all of us are aware of these challenges and would take appropriate measures to actually intubate our patients.
Thank you, sir. Sister Vinodini, I'm like, we are in the ER, there's a senior nurse and there's some of the juniors who will be assisting you. And there's an intensivist who is trying to intubate a sick pregnant lady. We all know that the assisting of an intensivist or anesthetist itself is a big job and a stressful job, crashing patient. In a pregnant lady, how do you manage it, and how does it differ in the nursing aspect?
Usually the pregnant mothers will have different categories of pregnant mothers. One will be the tall one and one will be the short stature. So actually managing airway in this pregnant mothers is usually a bit difficult only on a part of our side. So actually they'll be having a short neck. So they'll be developing laryngeal edema. So there will be difficulty in ventilation also. Since the uterus is growing up, there is difficulty in ventilation also. We have to consider in mind both the both the management for the mother as well as the fetus. So there is little bit difficulty in managing them to give the proper airway management because of their growing up the uterus also. So this will be the difficulties we will face, sir.
Thank you, sister. So coming back to Chawla, sir, and this can be taken by the other panelists as well. We know that ventilating an ARDS patient and especially CVRDS patient itself is a difficult aspect. And what are the difficulties in ventilating in a pregnant patient with severe ARDS, sir?
You know, this is definitely a very uphill task because ventilating an ARDS sometimes is difficult, and a lady who has a low chest compliance, and because of the diaphragm is up and there is a chest compliance is less, and then because of the ARDS, the lung compliance also decreases. So it is always difficult, but the basic principle does not change. You have to follow the lung protective ventilation strategy in these patients of severe ARDS. You have to ventilate them with a 6 ml per kg of ideal body weight. And the only thing is that the plateau pressure, normally because the chest wall compliance is high, so the transpulmonary pressure may not be high and the plateau pressure, what you see on a ventilator, may be high. So you have to tolerate little higher plateau pressure in these, unless you have a transpulmonary pressure monitoring, because that would be ideal to ventilate these patients. Then we have already discussed you aim for 95% of the SpO2, PaO2 of 75, PCO2 should remain below 60. You cannot apply the permissive hypercapnia in these, and you have to maintain pH, which should not, most of the time, these patients will not have that much of alkalosis problem. They will have more of an acidosis problem. So you have to maintain that with the respiratory rate as far as possible to maintain around that level, that the pH remains in the normal range. So, and then if they do not maintain, then, you know, one would be thinking that you can't prone them, but proning is possible in these patients. But only thing is, you can't prone them for longer time, 8 to 10 hours. You prone them and careful. And at the same time, when you prone them, your main responsibility is to monitor the fetus. You have to CTG monitoring or the fetal monitoring when you are doing the proning in these individuals. And the contraindications remains the same, like the hemodynamic instability, spinal instability, increase intracranial pressure. They're all then the pregnancy is not an absolute contraindication. That is the point which I wanted to say. If a patient requires, under the observation, you could use this modality to improve this refractory hypoxemia.
Thank you, sir. Thank you for Dedeep, yes, sir.
Yeah, I think the challenges of ventilating a pregnant ARDS is very well said. Just to add a point, this is 24 weeks of gestation. If she continues to have difficulty in regular ventilation, considering that the mother is very important, and considering that it's 24 weeks and we have advances in neonatal care as well, it will not also be a bad option to discuss with the family about early delivery of the patient to facilitate a good level of ventilating this particular patient, because in a matter of days she will return to pre-pregnant hemodynamics or otherwise. So that is another option if we find it a difficult to ventilate situation in this particular scenario.
That's true, sir. We all have seen in the COVID severe ARDS patient where it was very tough, and in fact that helped us a lot, going like shifting the baby, maybe an early delivery, safe delivery, and shifting into a proper neonatal care, especially where we cannot monitor the fetus that well as in a non-COVID scenario. Coming to that, Sister Vinodini, we know that it's a difficult task, and it's most of it's the burden will be falling onto the nurses. Proning, it's easy to tell rather than easy to do. So what are the difficulties? We know that it's difficult in a non-pregnant as well. In pregnant lady, what are the nursing aspects?
So coming to the nursing practical difficulties we face for the prone pregnant mothers means, if we put the mother in a prone position, means that the intra-abdominal pressure will be raised, sir. So there is a great task in monitoring the fetal heart, actually. So which leads to the low blood flow for the baby. The perfusion of the blood flow to the fetus will be reduced. So due to the hypotension, the blood flow for the fetus will be low. So considering in the mind the prognosis of the mother, we can counsel the parents, we can counsel the families, the well-being of the mother. We can just either terminate the pregnancy. We have to counsel in the way that we can terminate and we can go to the baby with a higher neonatal care facilities, or else we can counsel and we can say the pros and what are the do's and don'ts. So if we do like this, we can explain them the family counseling. This is how it's going to be happen. So fetal monitoring will be the most practical difficulties because the blood flow to the baby will be like very low because of hypotension, sir. So in order to monitor the fetal heart rate, you have to counsel the parents either to terminate the pregnancy in the right way to for the well-being for both the fetus as well as the mother.
Thank you, sister. We know that almost 6 persons are required for a routine proning of a non-pregnant lady. How do you manage in practical scenario with a heavily pregnant?
Yeah, sir. Actually, we'll just counsel the parents and we'll terminate the pregnancy because the intra blood pressure will be like increased. There is a risk of pre-rupture of membranes, which leads to abruption. So either the patient may go for miscarriage also. So it's better to counsel. We'll get the discussion from all the panels who are treating the patients, and we'll terminate for the prognosis of the baby as well the mother, sir.
Thank you, sister. Coming to the final question, both Dedipya sir and Rajesh sir can take this question. We have a like severe ARDS with refractory hypoxia. Like we're not able to ventilate her, and a few words about the role of extra cup. We all have done ECMOs. We, in fact, our knowledge and the apprehension has come down about ECMO after COVID, fortunately or unfortunately. So about like your personal experience and what are your recommendations about the ECMO and other extracorporeal therapies in pregnant sick patients, sir?
Hello.
You know,
Yeah.
Anyone. Okay, Devi, you take it, please.
It's okay if you want to.
No, it's all right.
Okay. See, basically, I think as you rightly said, with the use of ECMO, we've all matured, and we are now using it in many patients in whom it is clearly indicated. And if it is clearly indicated in a pregnant patient, I don't see a reason why it shouldn't be withheld for them as well. Of course, knowing fully well that in pregnancy, the chances of maternal and fetal bleeding is very, very high compared to the non-pregnant state. And explaining this, we would be able to actually use and expand ECMO. But having said that, I would still say that if you use ECMO as a choice only if we think delivery of a baby and continued ventilation of a patient in a pre-pregnant state, if you have not tried that out, and if that could be tried, I would say that try that out before actually pushing them to an ECMO. And I would not say that I have a lot of experience in ventilating patients with ECMO in pregnancy. We have a few cases, but I think with what we see in the literature and the cases that we have treated, I think it should not be too much of a challenge.
Rajesh sir.
I think I agree with him. I also, it is very uncommon for anyone to have so much of experience of ECMO in pregnancy at this stage of what is the progress of ECMO in our country. So definitely this is an option, and you have to think of the other option, the termination and the ventilation, if that is not there, and you've tried, and probably ECMO could be used in these patients. And of course, if you use in a pregnancy, because when you use this and you have to give anticoagulation, the chances of bleeding and all those complications can really complicate. So if the termination has been done, and because you start thinking of a mother more in such a patient when the patient has ARDS, and then probably it is not working out, then probably termination. And if still not working out, ECMO could be considered in these patients. But frankly speaking, we do not have much experience as of now, but this is an option which can be thought of in a refractory hypoxemia patient.
About one particular point about the anticoagulation part, was it in the same thing as in non-pregnant lady? Because there's a placenta to consider. excessive anticoagulation?
You know, anticoagulation, otherwise you don't use warfarin. The rest of the heparin you would use because ECMO would not be possible without using the heparin in these patients.
Thank you, sir. Sister, before we go to the other panel concluding marks, any experience with the ECMO in pregnant ladies? So nursing aspect, purely the nursing aspect.
Like we don't handle high risk pregnancy, sir, but we referred a sick patient who presented as a suspected here. So she is twin gestation. So we received as a suspected in women's hospital, and we stabilized the patient with all the, saturating, we stabilized the patient and shifted to MDCCU. Finally, there they have done all this proning of ventilation and all was done. We counseled, we terminated the baby. The mother went to ECMO, but unfortunately, we didn't have good results, sir.
Okay. Thank you, sister. I think Jude, do we have any questions from any audience? I couldn't find anything in the chat box.
No, we don't have anything yet, Doctor.
Okay. No problem. Then we would invite each panelist to have a concluding remarks, please, about
Sure.
the topic. Rajesh, sir, to start.
You know, I just wanted to say that whenever you are dealing with a pregnant lady, you are dealing with two people. One is the mother and the other is fetus. So whatever you do, you have to think about both when you take any modality, any tests to do in these patients. All those infections which can occur in a normal individual can occur in a pregnant lady. And when you investigate, the investigations remain the same, except you have to be a little careful and try to avoid the radiological investigation. And the drugs you use, they should be comfortable with the fetus, because you should not use a drug which is contraindicated for a pregnant lady. This is the most important. And as far as the oxygenation target are concerned, you should maintain the 95% oxygenation if patient is hypoxemic, and maintain the PaCO2 not beyond 60, even if it is on a ventilator, and pH below 7.48. And all these should be taken care of. And then if they require non-invasive ventilation, because there are high chances of aspiration, so you should try to avoid. And if a patient requires ventilation, all the strategies, they remain the same, lung protective strategy, and they can be prone as if they require. And the only thing is that you don't prone for a long time, you prone them for 8 to 10 hours. And ECMO in a rare patient where you are stuck with this. The only thing which I really wanted to say is that whatever you do, it is both for the mother and child. But if you are pushed against the wall, then mother becomes a priority. That's what I think. Thank you.
Thank you, sir. Dedipya, sir, along with your concluding mark, one question was there, I think, a hypothetical question where 34 weeks pregnant, will you induce the labor? I believe he's talking in the scenario where it is 24 weeks of this lady, and if at all, if she's at 34, will you induce the labor? Dedipya, sir.
Yeah, I think we've just answered it. If there is if you have time, then at 24 weeks you'll also try to see whether you can hasten lung maturity and be prepared for a delivery, and that same will happen at 32 or 34 weeks as well. So we'll try to push the pregnancy as much as possible towards term, but if at any point of time it is impossible, then it is endangering the life of the mother or otherwise, then definitely we would try to terminate the pregnancy and transfer the baby to the neonatal care and hope for a successful outcome for the baby. Because unless, let me put it this way, when you're talking about a pregnant lady, we're talking about a maternal resuscitation, a fetal resuscitation, we're talking about a maternal outcome or a fetal outcome. Unless you have a proper maternal resuscitation, it is impossible for you to have a good fetal resuscitation. And unless you have a good maternal outcome, it is impossible for you to have a good fetal outcome. So if pushed to the wall, you do not withhold any investigation, be it a CT. Do not withhold any treatment, whatever be the treatment. If it is in the only possible thing that you'll have to do to ensure best maternal outcome. You'll have to do it, because if you're not going to do it, it is impossible for you to ensure a fetal outcome. So that's the message. As much as both lives are precious, unless the mother is resuscitated and has an outcome, it is impossible to have a good fetal outcome. So that's number one. And if the fetal outcome is compromised, the best outcome for the fetus is to have an early delivery and wait, and hopefully that the patient would survive in the extended neonatal care setting, and which is all improved in our country in the last decade or so. So that would be something that we would really look forward to. So that's the question. I think I'll answer that. And concluding remark. Okay, my first concluding remark is thanks to Jude, Thomas, who's been coordinating it very well, and Ravi Mahajan for pushing people to get through this. And what should I tell about? And congrats to Sister Vinodini. I think she really pushed it and did it very well. And what do I say about Dr. Swarna Deepak, who's I just looked at the slide and the amount of information that you've put in through it. The questions were very, very apt, and you've researched and put in a lot of evidence to it. Well, I don't think so you needed a panel to take it through. You've put it that well. So I think it's a lot of homework. So congratulate you on that. And my concluding remarks would be that remember that a pregnant female is not an ordinary female. There are physiological alterations in pregnancy in every system. Understand those physiological changes and understand how they practically change a particular patient. So if a patient who's pregnant comes to you sick, remember that all the non-pregnant causes still exist in her, and there are additional causes that will be existing because she's pregnant. And likewise, if you're looking at infections, there are certain specific infections that are more common in pregnancy. In this particular patient, just to raise a point, if this was communicable acquired pneumonia, Legionnaires pneumonia is more common in pregnancy. It is uncommon in the non-pregnant female. So we need to look at it. And when you're looking at antibiotics, of course, some antibiotics would have a fetal toxicity. So always keep that in mind when you prescribe it. If you have an alternative choice, of course, if you don't have an alternative choice, we'll have to use that, explaining the risks of fetal toxicity to the mother. And remember that any scores that you use are not being validated in pregnancy. Most of the scores that you have that are validated in sepsis in pregnancy would be the SO score in pregnancy, and maybe the modified QSOFA, obstetrics QSOFA, and the modified obstetrics SOFA are the only validated tools in pregnancy in septic patients. And remember that resuscitation of the mother will ensure that you have good maternal outcomes and also good fetal outcomes. And when it comes to you to make a choice, don't hesitate to make the choice, because that is also in the best interest of the fetus. Thank you.
Thank you, sir. Thank you. Vinodini sister, final comments from you.
Yes, sir. So thank you so much, sir. I'm very glad actually to be a part of this panel. So thank you for every panelist as a doctor, as a doctor, for guiding me and giving me this opportunity. One feedback from my side is like usually we'll be having ACLS, BLS, PALS, NALS and all for all the training sessions. So like great doctors, can you as a doctor can guide us for the management of also for the advanced life support in obstetric mothers also, so that it will be very useful for us also, sir. So since we don't have any obstetric emergencies, we are just shifting, we don't know the complete routine of our hospital. So if you train us like in the way, we are also will be very helpful in managing. So with this pandemic, we have gained a lot of knowledge and experience how to handle and stabilize the patients with shortness of breath and all. So in order to improve our knowledge more, if you train us with good training with how to airway management of an obstetric mothers, what are the things to be done and all, it will be very useful for us.
Thank you, sister. And very valid point by you that I think you are basically quoting a Sanju, the quote in The Art of War. If you know how to fight your battle, half of your battle is already won. before you actually enter the battlefield. So all of us has to specially train ourselves in the handling and obstetric patients who are critically ill. I think maybe we need to have, either it's a doctor or nurse, we need to have a turns. You need to go and train the obstetric critical care. There is a special courses as well, and there are senior people who can train ourselves. Thank you so much, sister. And I would just conclude, I think that Subbareddy is just boarding a flight, so he left a message. So the final concluding remarks, as I think all the panelists have clearly emphasized, the pregnant ladies have a complex physiology. Complex doesn't mean that it's a bad thing, it's a beautiful thing. You need to master the complexity, and you need to make it simple. And most of the time you need to develop a habit of having a specialized team. We develop a habit of having a protocolized approach. And always when you're having a pregnant lady, as both the seniors has told us, think about the conditions which are specific to the pregnancy, parallel to not neglecting the conditions which are common to the non-pregnant ladies as well. And never forget the fetus, and you need to have a simultaneous fetal monitoring, and never forget to keep on pestering the obstetric team. Always you can call them and you need to ask them. And multidisciplinary approach, having a team at your hand, having an obstetric team, having an intensive care, having a neonatal care team, all of them in the house, it helps a lot. And because there are 2 lives at stake, and the results are equally gratifying. So thank you so much everyone for participating in this panel discussion, and my special thanks to Ravimajan sir and Jude for having us, and it's our pleasure. Thank you.
No, it was real pleasure, if I can say, to hear, today's discussion. Well done, team, and well done all. Real pleasure to hear you all. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir.
We'll be signing off, and have a good day.
Thank you.
Thank you so much, sir.